Good evening, everybody, and welcome to tonight's masterclass hosted by Orthopedics This Week. I'm Scott McLean, the Vice President of Research and Development at SpineWave. My background's in mechanical engineering and medical device development, and I'll be your moderator for tonight's class. We'll be discussing biomimetic implant surface technology and introducing SpineWave's new surface technology developed using Nano and Femtosecond laser technology. We are really excited to introduce our master faculty, starting with Dr. Barbara Boyan, Professor and Executive Director of the Institute for Engineering and Medicine at Virginia Commonwealth University. Also joining us is Dr. Paul Silvestri, a fellowship-trained orthopedic surgeon practicing at the Norton Leatherman Spine Center. And finally, Dr. Alex Vaquero, who is the President of the Rothman Orthopedics and Professor and Chairman of Orthopedic Surgery at Thomas Jefferson University. To our audience, please make frequent use of the Q&A button at the bottom of your screen. Starting us off will be Dr. Barbara Boyan. She'll be introducing us to the biomimicry concept in the context of titanium implant surfaces and sharing some of the evidence she and her team have developed over the years supporting the concept's effectiveness. We are also thrilled to have Dr. Boyan introduce SpineWave's biomimetic surface technology and to share her scientific findings working with the surface. For context, SpineWave has spent years developing a surface with features designed to emulate the topographical features within osteoclastic resorption pits using laser technology. Dr. Boyan.
I'm Barbara Boyan. I'm a professor in biomedical engineering at Virginia Commonwealth University, and I'm the executive director of the Institute for Engineering and Medicine. And I'm really excited to be able to share our findings with you concerning the biomimetic implant surfaces that have been developed by SpineWave. Let's get going. This is something that when I first saw this picture, I was absolutely thrilled to see that this was possible to achieve in a biomaterial. I think many of you have heard me talk about biomimetic surfaces and about osteoclast resorption pits. And I think most of you can kind of remember back when you were in school that in the bone formation that goes on in the body, that new bone forms on bone that has been resorbed by osteoclasts. And what you can see in this amazing micrograph by Dr. Watari, that as the osteoclast walks its way across a bone surface, it creates kind of a scalloped edge as it moves its body, and underneath its body, it releases hydrochloric acid. You remember hydrochloric acid. That etches out the mineral, and it leaves behind a collagen-rich matrix. If you look at this matrix, and you can see how the osteoclast has put its body down, resorbed, picked itself up, moved over, resorbed, picked itself up, moved over. You can see it walking across, creating this structure. But if you really focus in, as we have done here, and you look at this high-level micrograph, what you can see are ridges. And these ridges are very characteristic of the way collagen is laid down in the extracellular matrix of bone. Now, I've never seen a micrograph this beautiful before, but if you don't get my excitement, there's something wrong with you. And we're going to talk our way through this because this is really a special observation. This is the normal bone surface created by osteoclasts. This is how it looks in high magnification. Many, many years ago, we started to ask ourselves, what was it that you could do to a titanium surface to make it more attractive for bone to form on it? And this is one of our micrographs where we took bone wafers and we put osteoclasts on them, and we let them etch the surface for different periods of time. And you can sort of see that same pattern. You see these little scalloped edges. We didn't have the beautiful micrograph at that time to look down at the core, but we tried to recapitulate some of those features, and we did that on a dental implant that had a grit-blasted and acid-etched surface. This material is called SLA, and we were interested to see would the cells behave the same way on a metal surface as they were behaving on a real bone surface. So if you look over at this graph, you can see as longer that we etch that bone surface with the osteoclasts, that the cells, this is always our control. It's tissue culture polystyrene or plastic, because we can see, you can't see through bone and you can't see through titanium. So this is what they do on tissue culture polystyrene. They love to grow on tissue culture polystyrene, but they don't become osteoblasts very readily. But when we move them onto the osteoclast resorb surface, the numbers go down, the numbers of cells go down. Now, you could be concerned and you could say, well, something is wrong here. But no, it's not wrong. These cells, the cell number may go down, but they are becoming wonderful osteoblasts, and they are producing a protein that's associated with that called osteocalcin. This is a protein that they produce and they put in the matrix to help with their it's involved in many different aspects of bone biology. And now we want to see, did we recapitulate with the osteoclasts anything that was similar to what was happening on the titanium surface? And here is a machine titanium, behaves very similar to plastic. We make that surface rough, like this picture here, but still, when it's an osteoclast resorb surface, they behave much more like a fully differentiated, very happy osteoclast, and they are producing a whole lot of osteocalcin. So what is it about that osteoclast surface that is so special? And that's really what we're trying to now recapitulate in a material. To get a better understanding of what features have to be there, this is that SLA surface. You can see these kind of craters, these scallops that are formed by the grit blasting and acid etching. And if you look at the surface up close, you can see that it is not in ridges. It's grit blasted and acid etched. It's little smaller craters and smaller craters. It has a microscale surface and a submicron scale surface. We tried to recreate that surface in a model system. So this is made exactly the same way that you would make a computer chip. It's made by photolithography. And we were looking at the crater size, which you see here. Osteoclast resorption pits are 30 to 100 micrometers in diameter. And then we acid etched it. This is what it looks like up in high mag. And you don't see those ridges, but you do see that there is a microscale and submicroscale roughness to this. And the story holds that if we now look at the cells on this surface compared to the model surface, the cell number goes down and osteocalcin goes up. So we're pretty confident that comparing cell number to osteocalcin is telling us that these cells are becoming osteoblasts. Well, that's great. But what if we could get a surface that looks just like that surface that is at the basement of an osteoclast resorption pit? And I'll be darned if SpineWave didn't do it. So here we are. We are looking at the surface of a titanium aluminum vanadium disc, and it has been treated with the nanosecond laser, so nanosecond pulses of laser. And you can see how we get this kind of morphology. And if we then add on a femtosecond laser, even faster little pulses, all of a sudden, what we're looking at these ridges. And boy, if they don't look like the basement of that osteoclast resorption pit, I don't know what does. So we've created a structural element on a metal surface that is a real biomimetic of the biology. Now, I really want you to focus in on this because I get excited. And if you're not excited, I can't work with you. You've got to get excited. Here we are looking at it in lower mag. We increase the mag and we can see these little ridges. And if we get even higher mag, here's all these laser ridges that are forming. And here we add the femto laser. And wow. Is that not wow? That is wow. Okay, is this in your brain, in your memory bank? There it is again. Here's real biology. Here is what happens when we laser the titanium, aluminum, vanadium. Real biology, laser. Okay, so does any of this matter in life? And now we're going to look at, does it matter? Because that's beautiful pictures of very, very, very lovely stuff. And for someone like me, I'm now already, okay, what's going to happen biologically? So we're going to test two different versions of this. One is in 2D, where we machine the surface and then we treat it. The other is in 3D. We 3D print a surface, and that has a natural roughness to it from the 3D printing. You can see smoother, rougher. And we now do the nano femto processing, and that's a wow. Okay, so it does matter. And now we have cultured bone marrow, human bone marrow stromal cells, the ones that are going to migrate on when this implant is placed in the spine. And you can see here again that the DNA goes down on the surfaces as we move from plastic to titanium. This is a non-treated surface, but it's titanium, so the cell number goes down. But as we treat the surface, the cell number is reduced even more. Now, that doesn't mean these cells don't grow. They do grow, but because you can't have just one cell on a surface and have bone. But the number, by the time we measure them, which is 7 days or 14 days after we put them in culture, the cells have grown onto the surface and they've started to differentiate. And when they do that, they stop multiplying. That's why the actual cell number is less. It's not that they're dying. They're absolutely not dying. They are have already gone through divisions, and now they have started to differentiate. On the plastic, they just keep dividing. And here you can see just what biology tells us we should see. You see that the moving on to titanium, aluminum, vanadium, they start producing more osteocalcin, but on the nano plus femto lasered surface, they are becoming wonderful osteoblasts. And on the 2D surface, we see the same thing. We see the cell numbers go down, we see the osteocalcin come up. And that is an absolutely wonderful outcome. So if we go back and we look at the surface, what the cells are seeing as they migrate on, they are seeing these wonderful ridges that look just exactly like an osteoclast resorption pit. I want to thank you for listening. I hope that you feel the same excitement that I feel. I love it when you can recapitulate in materials something that actually exists in biology. The cell biologist in me is always happy to see something like that happen. And I'm really thrilled to be working with these materials. Thank you so much, SpineWave.
Thank you, Dr. Boyan. That was great. We're so thrilled to be working with you and your team on this exciting new technology. Dr. Boyan is a true pioneer in this field. I am going to take a little deeper dive now into the technology. It really has been an interesting journey, and we're excited to share it with you. You'll notice on the screen that SpineWave's technology has been trademarked Ticell Nano Advanced Surface Technology. We're going to take a step back now and talk a little bit how we arrived at this technology. So we always start with what we know. It really starts with the diminished usage of peak implants in the field. Really suggested to us that surface technology is important to surgeons, as surgeons saw fibrous encapsulation of peak implants and saw a significant shift to titanium implant usage. We've seen a trend of companies seeking biomimetic strategies for implants, and around that, there's a lot of marketing noise with not a lot of scientific evidence. In the case of Dr. Boyan and her lab, there is a growing body of evidence that nanoscale and submicron scale features promote cell signaling. And again, Dr. Boyan is responsible for a lot of that evidence. We also know that there really few technologies exist today to produce features at that submicron and nanoscale, especially in a repeatable manner. So as we develop this surface, the biomimicry aspect is really only one aspect of the design rationale. There are many things we're trying to achieve with the surface design, including durability. We want the surface to be able to withstand the rigors of implantation and biomechanical loading without fracturing or delaminating. We wanted a tactily rough surface that offered a lot of friction so that the position of the implant is maintained and the correction of the patient is maintained without retropulsion. We also wanted to include porosity. We believe porosity is important to provide an interlock between the bony anatomy and the implant to combat implant migration and retropulsion. Dr. Boyne spoke a lot about the cell signaling aspect and the nano technology aspect that we are seeking to include in this design. And finally, the economy of manufacture. We really needed something that can be made economically, that could be scaled, and could produce the surface very repeatably and accurately. So in doing so, we came across the femtosecond laser as a potential tool, and we were not the first to express interest in femtosecond lasers. Femtosecond lasers are being studied worldwide because of their ability to produce submicron and nanoscale features, and they're being studied for their effects on cell behavior. We like this option because the laser process is clean. It doesn't use any chemicals or of any sort. It's also very accurate and versatile and very repeatable. And when you pair this laser technology with modern automation techniques like multi-axis CNC and robotics, it becomes very scalable. And lastly, its durability. It's a subtractive process with no risk of delamination. So here's a look at our dual source laser texturing process. So we're talking about femtosecond lasers. We're actually using a nanosecond laser initially, and that's a bit more of an aggressive laser. So we can think of the nanosecond laser as kind of the chisel on the surface, whereas the femtosecond laser is more of a scalpel, more fine detail. So first, we are using the nanosecond laser to create a tactile microporous structure. And that provides a high friction interface between the end plate of the implant and the vertebral end plate. And you'll notice that there's pits and pores on this surface that are of a similar size to osteoclastic resorption pits. Second, the femtosecond laser produces submicron and nanoscale features. And as Dr. Boyne mentioned, these are the features that mimic the topography at the base of the osteoclastic resorption pit, the collagen fibers and fibrils present in that area. So in order to give context to the surface and to the features involved, what we're showing here is the Exceed implant. This is a top view. So you're looking at the end plate contacting surface of the Exceed implant, and we'll talk much more about the Exceed implant later tonight. And that circle that's drawn on that surface is the approximate diameter of an audio jack that you would plug in on, say, an airplane. So we're going to take a look down the barrel of that circle, of that audio jack, and this is what you would see. So this is you can see the rough textured surface, and this is what you see and feel on the implant surface. And if you look closely, you'll start to see those pits and pores that we were discussing. So I'm going to zoom in right down the barrel of this audio jack. Now we've reached a magnification of 300x, and now we can clearly see the pitted and pore structure of the surface. And you'll notice we have a circle drawn on here. This circle is 75 microns, which is similar to the diameter of an average human hair. And as you look at the pits and pores, again, you can see that they are of a similar size to that circle, indicating that we are in the range of the size of osteoclastic pits with these pits and pores. Now, if you compare this to an osteoclastic pit, you'll notice right away that the pits and pores that are produced are much, much deeper than the osteoclastic pits. And that's by design. We did that intentionally so that we could have that nice tactile rough surface. It's those deep pores and those protrusions associated with them that create that surface. So given the hydrophilicity of the surface and the ability of the surface to draw fluids and cells towards its surface, we felt that we would be able to maintain the function of the osteoclastic pit regardless of its depth. So we're going to now look a bit at how we quantify the size of these features on the surface. And at this scale, the micro scale, we use a laser confocal microscope, and that quantifies the surface roughness for us. And that's really useful in monitoring quality. That we have the same features from device to device. This is a very rough texture with an average roughness of 38.5 microns, which is similar to a heavy grit sandpaper feel. This technology is useful for estimating the size of those pits and pores, as we said, by tracing a plane through the surface. We can deduce the size of those pits and pores, and we estimate those pores to be about 50 to 100 microns in size. Again, replicating the size of the osteoclastic pit very closely. Okay, so now we're back to that human hair, and we're going to go and zoom in deeper. Okay, so now on the screen, you're seeing a circle that's 1 micron in diameter, and that is the approximate diameter of a single strand of a spider web. So, which we all, I'm sure, have seen a spider dangling from the ceiling, with the single strand of web being practically invisible. If that doesn't give it enough context, a single spider web you could fit 50 to 100 of those in a single strand of human hair. So at this scale, we're looking at submicron size features and nanoscale features. And you can see the ridges that have formed from the femtosecond laser, and those ridges approximating that 1 micron dimension that is also about the size of a collagen fiber at the base of an osteoclastic pit. If you look even a little bit closer, you can see the melting and recasting material along and between those pits has left very small features that are at the nanoscale. In order for us to quantify the features at this scale, we use a tool called stereoscopic SEM. We produce a digital reconstruction of the surface. Again, using a digital plane, we're able to deduce the size of those ridges and also the roughness of the texture at that scale. In this case, we estimate the size of the ridges to be between 1 and 2 microns, and that compares very well to the diameter of the collagen fibers from the literature. Okay, so we're back to now the spider web, and we're going to zoom in even deeper. Okay, so now we're truly looking at nanoscale. This is a magnification of 200,000x. We have a circle in the middle there with a diameter of 100 nanometers, which is roughly the average size of a virus, a flu virus. As we look at these features now, you can see that they're blurred a little bit, but the melt and recast of the femtosecond laser that has left these nano-sized features that are similar in size to collagen fibrils. Again, collagen fibrils roughly being 30 to 100 nanometers in size. And again, using stereoscopic SEM, this time orienting the planes between the ridges, we can deduce the size of those nanoscale features and compare to the size of the collagen fibril. So to give this a little more context, what we've done is we've imaged competitive implant surfaces, so competitive titanium implant surfaces at different magnifications, and compared both to the osteoclastic pit micrograph that we have, as well as the Testa Nano surface. So this is 1000x magnification. We have scale bars that are about 40 microns. And you can see in the bottom left that we're looking at the Testa Nano surface with the pits and pores that are roughly 50 to 100 microns in size, and how that compares nicely to the diameter of the osteoclastic pit. And again, we have much deeper pits and pores, and that is by design. The competitive implants, the 3D printed, plasma spray, grip blasted, and acid etched, you can see all have different levels of roughness, all in very random pattern, and you know that there's really no organized structure to the features. So the next magnification we're going to look at is 10,000x with scale bars of 3 microns. And this is a useful magnification to look at the ridges on the SpineWave surface intended to replicate the collagen fibers in the osteoclastic pit. And again, looking at the competitive surfaces, while there's again plenty of roughness, we're just nothing organized in that sort of manner to mimic the collagen fiber. And lastly, we're going to look at the submicron and nanoscale. This is incredibly high magnification of 75,000x. We're looking at 500 nanometer scale bars. And what's interesting when we get this to this level of magnification is how much detail is still present on the SpineWave surface in comparison to the competitive surfaces. Now, I'd love to show you the collagen fibrils in the osteoclastic pit, but the radiograph just doesn't have the resolution to get us down to that level. So you'll have to take my word for it on that one. But the literature that we have and the measurements we've taken, we believe that those little nanostructures do compare very well. And again, the detail on the on competitive titanium surfaces is just significantly diminished at this magnification. So in summary, the dual laser process that SpineWave has developed is a clean, versatile, and scalable process. It can be effectively applied to both machined and 3D printed substrates. It provides a durable, high friction porous structure on its surface. It aims to combat implant migration and retropulsion. It also provides measurable biomimetic representation of the size of or diameter of an osteoclastic resorption pit, the size of the collagen fibers present at the base of the osteoclastic pit, and the size of the collagen fibrils that those fibers are composed of. Lastly, with the work done in Dr. Boyan's lab, the Testa Nano surface increased osteoblastic differentiation of MSCs cultured on the surface over both machined and blasted titanium and 3D printed titanium. Thank you for your attention. I'm excited now to introduce you to Dr. Paul Silvestri, who will be speaking in on our first application of the Testa Nano surface on our Exceed biplanar expandable implant.
Good evening, everyone, and thank you for joining me for this masterclass sponsored by SpineWave. My name is Paul Silvestri, and I work at the Norton Leatherman Spine Center. I was a fellow here from 2012 to 2013, and I've practiced in New Orleans, Louisiana at the Ochsner Medical Center up until recently. This evening, we're discussing the Exceed biplanar expandable interbody device, as well as its Testa Nano surface technology. I've been fortunate enough to work with this device over the past 9 months, doing about 75 T-lifts with it. Briefly, the Exceed cage is a biplanar expandable cage with a unique surface technology that you've already heard quite a bit about earlier this evening. I found this cage to be extremely powerful in terms of its ability to recreate disc height as well as lordosis, and to avoid common pitfalls of T-lifts such as cage extrusion and end plate fracture. As you can see, the surface technology is only on the superior and inferior sides, which allows smooth passage of the cage past the neurological elements. The roughness of the surface technology seems to help prevent against cage extrusion. One thing that I've noticed with the Exceed cage, as opposed to other expandable interbody devices, is a significantly lower incidence of subsidence. I honestly have not seen any of these cages subside into the end plates, even with very aggressive attempts at disk space expansion. This is likely related to two fundamental properties of the cage. First, the cage has a biplanar expansion. So if you look at the cage on the left, compared to a conventional T-lift cage, you'll see the absence of a graft chamber in the Exceed cage. However, after the cage has expanded in two different directions, as you'll see in a video in a moment, you have a large graft chamber that allows you to backfill the cage after cage expansion. This creates greater surface contact and also, in my opinion, creates greater ability to restore disc height. Furthermore, the surface technology allows for rapid integration of the cage into the end plates, and I have not seen any evidence of cage extrusion. Cage insertion is very streamlined. Using a single inserter, once the nerve root is retracted, I prepare the disc space in a standard fashion. I still like to use the insert and rotate trials to estimate the height of my desired expanded cage. Like I said earlier, this cage is very powerful in terms of its expansion, and you can push it pretty far in terms of being aggressive about your ability to restore disc height. This inserter then allows you to insert bone graft back through the insertion handle without having to change it or change anything out from the cage, which I think is extremely safe. In this brief video, you will see how the cage can be not only expanded, but also backfilled with graft. Here you can see using the T handle to drive that wedge forwards, fully expanding the cage in a biplanar fashion. You will both feel and hear a click when the cage is completely expanded. Then the rod that drives the cage expansion is removed, and you can insert the graft packing device directly through the cage insertion tool. This is a very robust interface and allows you to aggressively backfill the cage as well as the disc space without any risk of bone graft extruding from between the inserter and cage interface. I'd like to show you two cases that I've done relatively recently demonstrating the power not only of the cage, but also the surface technology. This is a 64-year-old male with low back and bilateral leg pain. You can see on AP and lateral radiographs he's had a prior L2 kyphoplasty, has a trace L3-4 retrolithesis, as well as notable L4-5 disc collapse. His stenosis is largely confined to the L3-4 and L4-5 levels, and I thought he was a good candidate for an L3-5 T-lift using the Exceed cage. I'm a freehand screws first kind of person for people without significant deformity. You can see my initial x-rays on the left, and then my post-cage x-rays on the right. At the L3-4 level, you can see evidence of a hyperlordotic disc even on the preoperative radiographs, and I was able to put a 15-degree lordotic cage there for excellent maintenance and, in fact, improvement of lordosis segmentally. At the L4-5 level, it was a little bit more of a tight disc. This is the 8-degree lordotic cage there. And then this is the 4-month postoperative x-ray with no evidence of any cage migration, and I would say early bone formation, particularly in the L3-4 disc. This is another patient, a 72-year-old male with right lower extremity radiculopathy in the setting of a prior L5-S1 fusion, as well as a recent right L4-5 discectomy. He came to me seeking a second opinion for refractory pain. Preoperative imaging demonstrates recurrence of a right-sided L4-5 disc herniation and significant disruption of the facet as well as fluid within the bilateral L4-5 facets. I thought this patient was an excellent candidate for a 1-level TLIF, again, using the Exceed cage. Here you can see my initial x-rays with screws, and then post-cage placement. There are 2 lengths of the cages, and this is the shorter length, as this, I felt the disc space was a little short, although I probably could have been a little bit more aggressive in putting a longer cage and perhaps even the more lordotic implant in there. To recap, this is a biplanar expandable cage with a unique surface technology. I found it to be extremely robust, not only in terms of its ability to restore or recreate disc height, but also to avoid problems associated with TLIFs, such as cage extrusion or end plate fracture. I've been very satisfied with it, as well as the ability to place a large volume of bone graft through the cage once it's expanded. And this has been my go-to cage for TLIFs ever since I started using it in December. Thank you.
Thank you, Dr. Celestri. That was excellent. We've been pleased with the feedback we've received throughout the limited market release, and we are thrilled to announce that as of last week, Exceed is commercially available. Our next speaker is Dr. Vaccaro, and he will be introducing the next up technology in the SpineWave pipeline, the Testa interbody technology featuring the Ticell Nano surface. The first application of the Testa technology will be on our Testa TP pivoting TLIF system. Dr. Vaccaro.
My name is Alex Vaccaro. I'm a professor of orthopedics and neurosurgery at Thomas Jefferson University, and I am a true believer of true position. I've used this implant now for years, and what drew me to this implant was the mechanism and how it allowed me to center the implant in the center of the disc space and bring it as anteriorly as possible. So I'm a true believer of getting implant as anterior as possible, getting it to pivot symmetrically. Now, there's other things that I need in an implant, and I come back to the manufacturers. I'd like to have something that is as radiolucent as possible, have desirable properties in terms of its modulus, its stiffness, and also have something that end plates like so it can heal. And the Testa technology has sort of brought that all together. We've seen an exhaustive presentation on the Ticell Nano advanced surface technology, and that is great because bone cells love it. Collagen fibrils, cells attach to it, cells come to it, and it's perfect. I like it because it prevents graft migration. And I used to use other similar designed implants, but because of their peak surface and the surface technology, they tended to migrate. This type of technology is designed so as not to migrate, which is great. So I love the geometry. And if you look closely in the top left picture, you could see how this sort of a buckle design, and I'll show that further, because I don't want something as stiff as a solid piece of metal. I want something that mimics PEEK, that's more compliant. And we'll see that as we go forward with the various attributes of this technology. Now, take a close look at this slide. This is a brilliant design. You take a stiff metal, and again, people talk about the concept of modulus when they talk about an implant. You really should not talk about modulus in an implant. It's a material property. So a piece of metal has a modulus. You can take that metal, design it the way you want, and you could change its compliance. So if you look closely at this sort of buckle design, this allows compliance in the disc space, which in my opinion helps bone healing. So they've decreased the amount of titanium in the wall. It's still strong. It allows for radiolucency, but it also allows for some movement, which is the compliance that you want, especially in the disc space, as you want to induce healing. You don't want this implant to be too stiff because it then can subside. So it's a beautiful, beautiful design in and of itself. Now, we've talked already in this presentation about the Ticell Nano advanced surface technology. And then you take that and then you make pores, and the pores are between 400 and 600 because we know that various bone cells like that type of porosity. They sort of migrate into that type of porosity. And the Ticell Nano advanced surface technology allows it to be hydrophilic. So you can see the implant in the middle there absorbing blood in the bone cells, and that takes it into the central chamber, which is where we keep bone. So we have a large central chamber, if you look at the top left, to allow us to put the bone graft in the implant. The surface technology allows it in a hydrophilic way to bring the nutrients to that bone graft, which is great. And if you look at a lot of the different types of implants out there, you really don't have space for the bone graft. And it almost becomes a spacer rather than a grafting device. So we have to keep that in mind. Now, if you're familiar with the true position technology that we had in the past, it was great. You could do it minimally invasively. You don't have to drop your hand back or drop your hand forward. You don't have to pivot. You place the implant in, a few maneuvers with the handle itself, pull the trigger, and it rotates the implant exactly where you want it to go. And the bottom left picture shows exactly where the implant lines up. And again, take a look at the radiolucency. It's not a thick piece of metal. You could see through it except on its boundaries. So this true position technology, it's easy, it's reproducible, and it places it exactly where you want it to be placed. And there's etchings on the side of the instrument itself, so you can see the depth. So from a minimally invasive perspective, you don't have to move yourself or put tension on the skin edges, which is perfect. So it's something that surgeons like myself who want to put the implant as anteriorly as possible. And here's a perfect example. It looks like a shell. In that shell is the bone graft. So you're having it contact the end plates. It's compliant. So there's some motion. So sort of Wolff's Law, it sort of helps bone to grow. It helps the bone cells to be attracted to the surface contour. And if you look in the graft on the right, implant stiffness, that's a more important term to use. Implant stiffness, we should use modulus, as I said before. And you can see titanium. A piece of titanium is so stiff, it's going to subside. If you look at PEEK, it's exactly what you and I like. It's very, very compliant. And now we have the benefit of a metal technology, which we know that cells love. Cells love titanium in a general sense more than it loves PEEK, depending on the surface technology. And now you're taking something that's strong, ductile, compliant, and you put it in the space, and you have a stiffness that's almost similar to PEEK. So it sort of combines all the things that we want to do. So the selling point, besides the implant itself and how it helps fusion to occur, is the technology of delivery. That's an example. You can see the straight instrument. You see the little circle there. It allows the implant to pivot, and then you release the implant. So you have optimal control. You don't have to have a large skin incision. It could be a small skin incision to place it. And once you learn exactly where you want to place it, it's reproducible on every single case that you do. And here's a video that shows us exactly how this works. And I'll press play here. So you'll learn how to attach it, how to release it, how to loosen it. And there's a little switch on the side that you press, and you see how he's pulling the trigger and it rotates. And once you get it exactly where you want it to go, and look at that, perfectly placed anteriorly, symmetrical like a banana cage. And then you release the mechanism, you take it out. And there's a little metal bar on the side. So I've done so many of these cases where I want to remove the case for whatever. Say the patient at a later date needs a revision for whatever reason. Say there's an infection. There's a little hook that goes in and hooks on to where this instrument attaches to, and you just put it around and use a slap hammer and take the graft out if it wasn't completely healed. So this is the type of design. The implant itself, I love. The surface technology is one of a kind, and it allows bone cells to adhere. So I think SpineWave has really done a great job in introducing this technology to the spine surgeon population. I want to thank you for allowing me to give my opinion on this technology. Have a nice day.
Thank you, Dr. Vaccaro. That was excellent. Testa TP will be the first of many devices in the SpineWave pipeline to feature Testa interbody technology, and we expect limited availability of the Testa TP system at the end of this year. Thank you to our master faculty for their talks, and we now have some limited time for some questions from our audience. Again, if you have questions or comments, please use the Q&A button. Our first question is for Dr. Boyan. I noticed in early slides you were referring to decreases in cell number. When you showed the SpineWave results, the chart said DNA. Can you explain the change from cell number to DNA?
It's actually the same number. So every cell has the same amount of DNA. And when we want to quantify something really exactly scientifically, rather than counting the number of cells, we actually measure the amount of DNA. And you can divide by the amount of DNA in a cell and you would get the number of cells. So it's just a more accurate scientific number. It's telling the same story.
Thank you, Dr. Boyan. Our next question, are there any concerns about your ability to position the implant in the desired location with the increased friction/roughness of this surface? Dr. Vaccaro, can you comment on that?
Sure. What happens is I hate fluoroscopy. So when you get used to it, and you may have to use fluor initially when you use this product, but you get used to the depth because of the etchings on the side, and you get used to exactly where you are in the disc space when you pull the trigger to make it symmetrical. So it depends on how you prep the disc space. You understand that you need to prep it to a certain size and then slightly undersize the implant itself so you don't get caught up in having an oversized implant that prevents you from placing it exactly where you want. So you want to have a little bit of friction, take it to where you know, and after, like, everyone knows who does this procedure, after about 10 or 15 procedures, you just know exactly where you are without getting an x-ray. Now, if you want to use fluoro, which I'm totally against, you could use fluoro to position it on the AP and lateral. But I'm going to tell you right now, radiation is your enemy for the rest of your life. So just get used to understanding the equipment on how to know the depth and the symmetry in the disc space itself. And with this technology, you can do it. So slightly undersize the implant and you shouldn't have a problem, because once you expand it, it's not a problem for the expandable, but for the tie cell, you know exactly what to do. So after you let off the distraction, it'll close down on a static implant itself. Thanks, Scott.
Thank you, Dr. Vaccaro. Dr. Celestri, you have a lot of experience with the surface now. Can you comment on the ability to place the implant where you want it?
Yeah, and I couldn't agree with Alex more about that you want to avoid fluoroscopy as much as possible for your entire life, because your cumulative radiation dose is every single x-ray that you've ever been exposed to, not what happens during one case. So that's really important for all the trainees to remember. As much as we've talked about surface roughness, the cage is not rough in any way. Like it does not feel like sandpaper or anything like that. It slides in very, very smoothly, especially with the Exceed. And I see Alex's point, if you really want a cage anterior and you're using a rotating cage, I think somebody may have not picked up on it. He's distracting either on the screws or on the lamina, right, to help get a cage in that's, as big as possible. But with the expandable cages, you can really get a big cage in and you can pretty much put it wherever you want. I usually try to strive for maybe underneath kind of the pedicle or crossing midline if possible. I don't tend to use banana cages. I use straight cages. But again, let's make it clear. The cage itself is not rough in a way that makes it difficult to insert at all.
Thank you, Dr. Celestri. Okay, next up here we have another question for Dr. Celestri. You said this has been your go-to implant since you began using it. I'm assuming this is referring to the Exceed implant. What specifically has made this your implant of choice?
Sure. So a couple things we discussed. First, I haven't seen any evidence of cage extrusion, which is, one of the things you really hate to see in the early postoperative period. Two, its ability, as I mentioned, to really aggressively expand discs. And then three, and this is something that Dr. Vaccaro mentioned as well, the ease of insertion. When you're teaching residents, when you're teaching fellows, you want to have something that is robust, but that the connection between the implant and the inserter is very, very strong. It's not going to fall off. It's not going to misfire. It's not going to fail to expand. I really haven't seen that at all. So it's really, really good sort of teaching tool as well, because it's just such a strong and robust system that just doesn't fail in my experience.
Thank you for that, Dr. Celestri. Next question. Do you believe there's a true clinical benefit from this type of surface? Dr. Vaccaro.
So it's interesting. All the science out there tells us that cells like metal, as Barbara Boyan just said, and she went over it in detail. So then when there was a craze to go back to a peak type cage, and I thought that made a lot of sense when they went to a peak with the appropriate type of surface roughness and appropriate type of porosity. So if you had equal designs of a PEEK cage and a titanium cage with the appropriate porosity, it is my belief cells like metal better. So I think this is the preferred metal. Now, I love invisible cages. Be a little bit to the right, a little bit to the left. I love it. I like to see bone graft. So I would say if God gave me an invisible metal cage, I would go for it. But God didn't give me an invisible metal cage. So I like this cage because it likes metal. And I like the fact, as I said before, don't get confused on modulus. Modulus is a material property. If I hollow it out, if I make it porous, it's less stiff and it's more compliant. Therefore, it won't subside. So if I had my choice, I would like to have a metal surface, but I like to be visible. So I can't have everything, but I like this design.
Thank you, Dr. Vaccaro. Dr. Celestri, same question.
Yeah, absolutely. I think that this is sort of the next frontier, right? Surfaces, and I think you made the very clear distinction. This is not a coating, right? This isn't a PEEK cage that's been coated with something. And I think all of us have used those cages, and certainly we've seen delaminations from that, right? If you have, metal on PEEK, there's going to be failure at some point. With this, surface technology, rather than specifically just a coating, I really think, and you can look at Dr. Boyen's work, and it's promoting bone growth, right? And there's a lot of ways you can promote bone growth, right? And you can use expensive biological growth factors, but at some point, and certainly in my hospital system, we look at that. We look at the cost per case of a TLIF, and we're saying, hey, look, why is it that your total cost per case is significantly more than a different individual's? And it really comes down to implant choices and biologics. And if you're using expensive biologics to achieve a fusion, rather than good surgical technique and choice of implants, I think you're fighting a losing battle in the long run, because you're going to just have to change or fail.
Thank you, Dr. Celestri. Dr. Boyen, can you comment on the, on this question, and in particular, any work your lab has done to try to link the in vitro results with in vivo?
Yeah, I've actually really enjoyed your answers, both of you, on these questions, because it's really rewarding to hear. What we have found is that if bone marrow stromal cells, what we used to call mesenchymal stem cells, if they are on a surface that gives them the signal to become an osteoblast, they start producing factors that, including bone morphogenetic protein themselves, which they secrete out into their immediate environment, and other cells in the environment. Not every cell can sit on the surface, so there's cells migrating in as bone is coming in by creeping substitution. There's cells that are coming in on the clot that has formed during the surgery, and they get these messages as well. But what is also really valuable to know, and we haven't tested it yet on this surface, but Scott, we're going to have to now, is if they are on this biomimetic surface, then they might upregulate receptors that lets them even know these proteins are present. And that's really important, that they can make this stuff and that they can respond to it. It is all these fancy biologics. And I love Dr. Celestri's comment about the coatings. Absolutely. If you engineer it correctly in the first place, and I was taken with the care that SpineWave has put into figuring out how to manufacture these implants. If you make the implant right in the first place, you really don't need those coatings. And in fact, I think that they could even lessen the value of the response that you would get from a well-designed surface.
Thank you, Dr. Boyen. Okay, next question. How does a laser process work inside porous implants? So I can take this question. I think what the question is asking is, if you have a porous implant, how can that laser access the various struts that are present inside that porous implant? And as you can see in the slides that Dr. Vaccaro presented, we do have porous implants in development that include the Ticell nanotexture on the porous structure, and that's really due to the ability of the laser to work at different depth fields to access those different areas of the porous structure. Next question, is there any issue with osteoporotic patients with end plate collapse and an aggressive disc expansion? Dr. Celestri, can you take that one?
Sure. I mean, absolutely, right? And I think that there's a couple of strategies to mitigate that. So first, as both Dr. Vaccaro and I mentioned, we use some sort of distraction, right, to help enlarge the disc space. So that's either, using a laminar distractor to distract on the residual lamina of, say, L4 against L5, or using a pedicle screw-to-screw distraction system. So that's one way to help open up the disc space. So rather than just relying on the implant to recreate your lordosis, you're first opening the disc space. As I mentioned, I then trial. Now, previously, or if I'm using a non-expandable cage, if I can get an 11 in, I'll probably end up putting a 10 cage in, sort of like Dr. Vaccaro mentioned. You might want to undersize a little bit. With the Exceed expandable cage, if you can get an 11, insert and rotate cage in, I would definitely put in 11 if you're comfortable, because again, the cage, although very powerful in terms of its lifting, you've already done a lot of work of the expansion already. Now, in a patient who doesn't have osteoporosis, if you want to push it even more, right, if you can get, well, I got an 11 in, but this device is powerful enough, I think I can probably put a 12. So again, you have to know your patient a little bit, right? You don't want to be trying to slam the biggest possible cage into really, really weak end plates. But at the same time, within reason, I think you can have a lot of confidence in this cage's ability to help sort of expand the disc space.
Thank you, Dr. Celestri. Question we have here is, this is a process question, so I'll take this one. What is the processing time with the combo of Nano and Femtosecond on an inner body? I can't tell you to the second, but I could tell you it's probably in the order of roughly 1 minute per implant. And another process question here, is there a need to clean the product surface after laser texturing? There is some residue from the texturing process that is removed via conventional cleaning techniques. So we are now out of time. I want to thank the audience for those thought-provoking questions. This has really been an outstanding discussion. It's really truly amazing to witness the progress of the manufacturing and the imaging and measurement techniques to allow these types of development in biomimetic solutions. Thank you to our master faculty for a great course, and thank you to our audience. And finally, a recording of this masterclass will be available over the next couple of weeks at ryortho.com. So please watch for that. Have a good night. And this ends our masterclass on biomimetic implant surfaces.